Okay, good morning to everyone, and welcome to your questions answered about closed head injuries with Dr. Myseros. These questions are coming directly from the evaluations that you guys filled out for virtual trauma core for closed head injuries. If you would like to get CNEs, this should be probably around one CNE and one trauma hour. In order to get that, you just need to view the entire session today live or watch it completely on YouTube, and then complete the online evaluation and attestation of completion. The evaluation link will be given at the very end of this.
May I?
And if you could please keep your mics muted if you are not asking a specific question. If you do have a question during this time, feel free to unmute yourself or put it in the chat. And because we are not just answering questions from today that we already have preloaded, but we can answer some live. All right, so the first question that we have, Dr. Myseros, is how do we decide if we need ICP monitoring? And you're muted. Dr. Myseros, you're muted.
Okay, got it?
Yeah, there we go.
So the reason we even monitor ICP is when we don't have a neurologic exam to follow, right? I mean, if there's a kid who is following commands, monitoring their ICP is of no use. Even if their ICP is 100. If they're awake and alert and following commands, usually kids who have an ICP of 100 aren't doing that, right? ICP of 100 is not compatible with life, but I'm just, using just for an analogy. So we typically monitor kids who have no exam to follow. Typically that's a GCS of 8 or less. If they're awake, not following commands, but they open their eyes, arguably there's no need to follow that child unless they're not opening their eyes. But the criteria we use in this hospital, most hospitals, is quote unquote severe head injury, Glasgow Coma scale of 8 or less.
Okay. Our next question is, do I actually need to wake up a patient every hour throughout the night to do a neuro check? And I'm assuming that's when they're ordered Q1.
So that depends on what the order is, right? So if if the request is for every 1 hour neuro checks, then yes, you do. Now, a different issue is what the utility of that is, right? If you're waking up a teenager every hour, about 10 hours into that, they're going to be so exhausted that how reliable is their neurologic exam? That's a different question and arguably a difficult one to answer. But yeah, you do. You have to see if they're, particularly if you're concerned about their sensorium, their level of cognition, right? If they know their children's and then all of a sudden they don't know what their name is, no matter how tired they are, that's a problem. And the only way you pick that up is if you actually ask. So I would say, yes, you do have to actually wake them. It's torture, right? It sounds like you're almost being abusive to the patient and the family, but it's important.
What can you do when you notice something weird, but the patient appears clinically okay?
I would have to ask whoever asked the question what they mean.
Yeah, so I'm keeping all of these questions anonymous, but when I look at this question, you have a kid that is answer. So say you have like a kid that's answering questions, looks okay, pupils are equal, but something just doesn't seem right. So maybe their affect is off, or maybe their left arm seems a little twitchy, like just something that's kind of like out of the ordinary, but isn't like impacting their vital signs. It's just kind of something off.
First of all, make sure that the exam that you're getting, whatever it is about them that's concerning you is consistent, and it's not some aberration, right? So if it's a real concern, you should have one of the residents or fellows or even the attending come and look at the kid. I wouldn't push the panic button quite yet, nor would I just automatically take him down for a CT scan or her down for a CT scan. You might ask the family, does Joey or Jill ever do this at home? Try to be a little bit of a detective about what's going on, because if they're clinically okay, then by definition they are okay. I wouldn't get too anxious, but we're all sort of detectives in what we do. So if there's something and your spider sense is going off, and you're not trusting what the situation is, have somebody else, a fellow nurse, a physician, come and examine the child and see what they think. But always ask the family, particularly if they're there, if this is something they've seen before, because they might say, yeah, when Joey's really tired, he just acts out or doesn't seem quite right. He does this all the time. That would be important to know.
Yeah, I think that's probably what people were getting at when they did ask that question, because I feel like we've all been there, especially our newer nurses, of like looking at a kid saying like, I know something isn't right, I'm just not quite sure what to do with it. But I think noting that asking the family is probably one of the best things. We also had somebody comment in the chat. I think that if you would notice an anomaly or weird, always report it and document it. And even if it is to trend and monitor. Any thoughts on that?
You should, particularly in this day and age, you should document everything, regardless. Not just to protect yourself and protect your team, but somebody may go back one day, and if the kid has an issue, and say, oh yeah, he's done this before.
And that is a nice way to say, like, okay, his left hand was twitching, but dad said he does this, every Thursday, every month. Okay, is there a certain place within the brain an EVD must be placed?
So this is a very specific question about an EVD, an external ventricular drain. So an external ventricular drain, by definition, is in the ventricle, right? It's in the fluid space of the brain. So you can access the ventricle depending on how big or small it is from various positions on the head. All we have to do is look at our shunt patients. So I personally tend to put in frontal catheters, just in front of the coronal suture into the anterior horn of the lateral ventricle. Most of my partners put shunts in the back. They put them through a parietal occipital approach behind the ear into the occipital horn of the ventricle. And you can put an EVD in either. The thing is, to put it in the back, you really need to have the kid's head turned. It's in the operating room for a shunt. It's convenient. At the bedside for an EVD, it is not convenient. Particularly, you don't want to, if your kid is sick enough that you're putting an EVD, the last thing you want to do is turn their head and do anything that might compromise the jugular veins, cause venous hypertension, contribute to increased intracranial pressure, on and on. So usually we put them anteriorly at or in front of the coronal suture. It's about usually at the mid-pupillary line, or about 2.5 centimeters off midline. And we put it into the anterior horn of the lateral ventricle. It's usually the fattest part of the ventricle, and a kid who doesn't have very big ventricles is probably the easiest to hit. Mind you, you're at the bedside. Usually it's one of our residents or our PAs, and they're trying to put a catheter into a fairly small space without seeing it. So we have landmarks we use. We use the intercanthus of the ipsilateral eye. We use mid-pupillary line. We know the catheter in a full-grown kid the ventricle should be at about 5 centimeters. So there's various criteria we use to put it in. If the ventricles are big, it's a lot easier to put the catheter in, but it goes by definition in the ventricle and typically in the anterior horn of the ventricle.
I had never really thought about this. And I've taken care of a lot of EVD patients, and I always knew it was in the ventricle, but I didn't really think about like the method behind like which ventricle you put it in and why.
So, the ventricles should, in a normal anatomy, all of the ventricles communicate, the fourth, third, both lateral ventricles. Whether you put the EVD on the right or left side really doesn't matter. We tend to put it on the right side because, well, some people it's their preference because of their handedness, but I would recommend. I've seldom put in EVDs, right? Our residents and our PAs do, but I usually go for the right side because most people, the majority of people, are right-handed, and most of them have their language function on their left side. Even the majority of left-handed people have their language function on the left side. So the point is that if you had a complication, if you had a bleed, a brain bleed, either intraventricular or intraparenchymal, in the brain, you'd rather have it in your non-dominant hemisphere. You'd rather have it on the side where your speech is not. And that's why I typically suggest the right side. Plus, most of our residents and PAs are right-handed, and they're passing the catheter with their right hand. And it's a little easier to pass the catheter medially with your right hand than medially from the left side with your right hand. That's a nuance, but that may be a preference.
No, that's really interesting. You're answering questions I didn't even know I had, so that's great. What precautions should we have for a closed head injury in the emergency department other than just observe and report symptoms?
Well, precautions and observations are two different things. So there's not many precautions you can take in the emergency department. Any kid who has a head injury should have the head of their bed up, whether it's a minor head injury or severe head injury. That's the very first thing you ever do is put the head of the bed up because it allows for improved venous drainage. The corollary to that is if they're flat, they're retaining venous blood in their head and they increase their intracranial volume and by definition increase their intracranial pressure. So when they're up, when they're sitting up, their intracranial pressure goes down invariably. So that's the first thing. You put the head of the bed up, make sure there's nothing including their neck. If they're a trauma patient, they have a collar on. Make sure that the collar isn't so tight that it's compressing their venous outlet, their jugular veins. Other than that, there's nothing that you can do that I can think of precautionary other than monitor their vital signs and examine them. And of course, if there's something on exam that's concerning or that changes, alert the ER doc or one of your other nurses, and things may escalate depending on what needs to happen. If the patient's not intubated, maybe if they're stopped following command or they're having difficulty breathing, they need to have their, the AB. Never forget the ABCs, right? So ABCs are whether it's a head injury or a pelvic fracture or a drowning, it's always ABCs for us and everybody else.
That's a really important point. Like I said, think sometimes we all want to get like super complicated and get into like very granular aspects, but if you do that and you forget about airway, breathing, and circulation, you could be you find yourself in a mess. In closed head injuries, is there any one vital sign that typically changes first?
Probably, and I'm not basing this on literature, but just on experience, probably heart rate. Heart rate's pretty sensitive. I can tell you when we're doing surgery in or around the medulla, the lower part of the brainstem, where all this stuff is controlled. Minor little changes will cause a change in the heart rate, and you can hear it sometimes. You can hear the pulse ox, the anesthesiologist pulse ox, and you'll hear it go beep 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 Now typically the anesthesiologist say, hey, we got significant bradycardia, and we back off from what we're doing so the heart rate can come back up. But it's even in a kid who has an arterial line where you have continuous blood pressure monitoring, the heart rate, our ability to monitor, our ability to pick up heart rate changes is so much faster than it is with anything else. So by the time you have a blood pressure change, things have escalated. And so heart rate, to answer your question.
Okay. What are more specific signs when infants and toddlers are deteriorating from closed injuries?
There are actually well, let's address infants for a moment, because they're different from any other patient who has a closed fontanelle, right? So an infant, almost by definition, has an open fontanelle. So aside from the usual things that you would see in any patient, which is a loss of sensorium, more sedated, more lethargic, more irritable, they stop talking, they stop moving, sort of obvious things. A baby has a fontanelle. So if their fontanelle goes from soft to firm or from firm to tight, that would be evidence that the pressure in the head is going up very rapidly, either from swelling of the brain or from a clot or from an enlarging clot or from a stroke. So in a toddler, they may go from being, obviously if they're awake and attentive and happy and then they become grumpy or inconsolable, that's a fairly acute change. If they're inconsolable to begin with because they were in a car accident and they have a broken leg and they become lethargic and unresponsive, those are the things that you worry about. Without having an ICP monitor or even a blood pressure or heart rate monitor. I'm assuming that's what the question is. If we didn't have the ability to follow very specific, vital signs, what are the things you look for? Those are the things you look for.
I think it's like those subtle pediatric differences of, I think everybody knows if somebody goes unconscious, that's a thing. But I think the point that you made about like feeling the fontanelle in infants, and then if you have like a happy toddler that's now grumpy and inconsolable, that's a problem. Those can be subtle if, especially pediatrics is newer to you.
Yes.
Okay. When a bone flap is removed during surgery, do you put it in the patient's abdomen until it's ready to be replaced?
In this hospital, typically we do not. A lot of the times that we do this, we're taking off a large bone flap because we want to do a big decompression, and that would be a really big incision to put on a baby's abdomen. That being said, in some places, that's all they do. And what we do is we put it in the freezer. We put it in a freezer. And when it's safe to put the bone flap back in, we put it back in. Now there's the good thing about doing that is you don't have to put an incision on the belly. The bad thing about that is twofold. One, you're essentially taking a piece of bone and devascularizing it, right? It's going to, by the time it comes out of the freezer, it's going to be dead for all intents and purposes. There won't be any living cells in it. Which means that when you put it back in, you're putting in almost a foreign body. It's not a foreign body, it came from the child, but sometimes that bone will not fuse, will not heal, will not grow. That's one issue. The other issue is it has a higher risk for getting infected because it's been in a freezer where it's been devascularized and there's been nothing protecting it. So sometimes we do this and we put the bone back in and we see the kid back. I must say we don't have infections very often, but we'll see the kid back and the bone just starts essentially disintegrating because there's nothing to keep it alive. And we end up in the long term having to do a cranioplasty, fixing the hole. So in a lot of places, if the putting it in the belly issue is nice because it's always with the kid. If somebody were injured out in the field during conflict, they always put it in their abdomen, because that patient, that soldier, he or she would probably be transported elsewhere, and they'll have their bone flap with them, right? Because it's in them. Not to mention the fact that it usually gets stuck and vascularized, and it's a nice healthy bone when you put it back in the head. So in our institution, we put it in the freezer, and we put it back in the patient as soon as we can, to avoid the two things that I mentioned below.
Yeah, I think we have another one about, okay. And so how long is a bone flap that is preserved, so in the freezer, good for? And how do, like, what do you put around it? I mean, do you just put it in a Ziploc in the freezer, or is it in a special?
The nurses put it in a Ziploc, yeah. And I think the freezer is minus 70 degrees. I'm not sure about that. I wouldn't write that down because I'm not sure about the temperature. But yes, it's in a freezer. It's in a Ziploc bag, and when we thaw it, when we put it back in, it gets thawed, and usually we put it in some antibiotic solution before we put it in the head. How long is it good for? You know, I suppose the more important question is, how long does it take for a bone flap in the freezer to die, right? How long does it take for anything living in it to not survive? And I don't know the answer to that question. It probably doesn't take long. But usually we like to replace a bone flap within 6 months. In my own opinion, we recently had a little girl who came to us for unknown reasons with brain swelling. We thought she might have a tumor, she might have a stroke. And I took off her bone flap and I actually did a brain biopsy. And I put her bone flap back in about 3 or 4 weeks later, as fast as I could. So when do you decide to put the bone back in? You decide to put it back in when you think that there's no longer a risk that putting it back in is going to cause any pressure. So whatever area you decompress should be soft. Because if you put it back in and the brain's still swollen, obviously you're not doing the kid any favors.
Okay. Is there a way to determine the seriousness of a head injury without imaging?
Yeah, by exam, by neurologic exam, right? So that's how the Glasgow Coma score was first developed in Scotland, right? I think I mentioned in my talk last time that the Glasgow, although we use a Glasgow Coma score to communicate the severity of any neurologic impairment, whether it's from trauma or from stroke or from hydrocephalus or from a brain tumor, it was developed specifically for trauma. And a Glasgow, if you tell somebody a kid's Glasgow Coma score, that tells you exactly the seriousness of their head injury. If their Glasgow Coma score is 15, their head injury is minor, if at all. If their Glasgow Coma score is 3, their head injury couldn't be more severe. Now, of course, there's nuances, right? There are kids who may have a Glasgow Coma score of 11 who look good, and Glasgow Coma score of 11 who look really bad, depending on how you scored them. Are they intubated? Are they not intubated? You know, have they, is their temperature a little bit low, so their GCS is not very reliable? Is it possible that they were, you know, they just got a hit of fentanyl and they're a bit sedated? But the answer to this question, it's actually a good question, because the answer is very, very simple. Their exam. That's how you tell the seriousness of their head injury. As a matter of fact, their imaging may not correlate with their head injury, right? If you have a CT scan in a kid who's had a shear type injury where they've hit their head very hard, their CT scan may look perfectly normal and they may be a GCS of 4. So the imaging may not correlate well with the severity of exam. And the corollary to that is, or I should say the polar opposite of that is a kid who looks perfectly fine, they have a little swelling on their head, you get a CT scan and they have a massive contusion or a massive hematoma, but they look fine. So imaging and exam don't always correlate. They usually do. If you have a kid with a GCS of 3, I can tell you their CT scan is probably going to look awful. And if you have a kid who has a GCS of 15, their CT scan is probably going to look pretty good. But sometimes they don't correlate well.
If you had a patient with a GCS like under 7 and you did the imaging and it looked fine, would you still like what would you do?
So what's going to happen is that the ICU is going to ask us for an ICP monitor. We're going to say, well, look, the brain looks fine. We can see the CSF spaces over the convexities, the cortical sulci, fine. The basal cisterns, the little smiley face, all the CSF around the brainstem looks fine. I can tell you with 99% certainty that this child does not have intracranial hypertension. I'm not going to put an ICP monitor in. Well, it's hard to follow their exam, right? So what I would do if you're getting pushback from us, I would get an MRI, because an MRI will show you if they have a diffuse axonal injury, if they have this shear injury, and I would just wake that kid up. There's no sense in sedating parallel. I think there's a question later on about the sort of the protocol for managing head injury, but I wouldn't go through the protocol of managing head injury if an MRI shows a shear injury with no evidence for increased pressure. I would just wake that kid up. You're going to drill a hole in their head and do something to their brain that carries some risk for a very small benefit.
Yeah, that makes sense of like what are you really trying to do versus what is the risk for the patient. And that's pretty invasive if it's not really needed.
It isn't. We seldom have problems, but it's a procedure, right? I mean, you're drilling a hole in the head and passing something into the brain. But by definition, that carries some risk.
Yeah, no, it's also it's a lot. Is there a time frame to begin medical interventions, like going to the OR, in which we could prevent devastation for patients with CHI?
I'm not sure I completely understand the question.
I think that what they're saying is if a kid gets a massive head injury that needs the OR, is there a specific time frame? So like they hit the door of the trauma bay. Is there like a magic time that a kid needs to get to
No, I
the
mean, there have been studies. I remember an adult study on subdurals. If you get a patient, if you remove a subdural hematoma in less than a certain amount of time, I think it was an hour, I don't remember, from the time of the injury, the outcomes were very different than if it was past that time. So for any surgical patient, the sooner you intervene, the better the outcome is going to be. That's intuitive, right? That makes sense. Now, a lot of it depends on their exam. So we see kids with really big epidural hematomas that are astoundingly big, and all they have is a headache. Well, that kid, whether you operate on him in an hour or in 2 hours, and they still have the same exam, their outcome will be the same. The problem is that if you wait, particularly with an epidural, which can grow very quickly, if you say, wow, this kid has an epidural, but he or she looks fine, we'll just wait for the next OR to open up rather than shoving it down their throats and doing it right now. And they blow a pupil, then the cat's out of the bag. So making that decision sometimes is very difficult, because if you remember my previous talk, I have seen kids with very large epidural hematomas and very, very few symptoms who I've not operated on, and they go away. And that, making those clinical decisions depend on the kid, on the location of the clot, on the location of the swelling. Is there a concomitant history for, or did they need to be intubated because they were hypoxic? Do we anticipate that they're going to swell? So it all very much depends. But generally speaking, for any neurosurgical patient, surgical patient that needs to go to the operating room, the sooner the better. And if you can't get to the operating room, you mitigate the risks as best you can. Head bed up, hyperventilate. If you have to, if they've blown a pupil, you give them mannitol or 3% saline. All the things that you would do to manage head injury in the ICU in a non-surgical patient. You hit them hard and you hit them fast to try to decrease the pressure and avoid them herniating.
There's some of the nursing aspects of head traumas, like the management on the floor, recognizing signs of decompensation. I think this question is asking for specific concerning signs if a patient's on the floor with a head injury?
I think all the things that we've talked about, you know, a change in their mentation, going from, certain behavior to something that's more concerning. Obviously, vital sign changes, respiratory, that includes respiratory changes, right? If they're, usually you won't have a respiratory change until you've had a hemodynamic change. It's seldom that a kid will, start having agonal breathing if they haven't already been in a coma. And also listen to the parents, they know their children better than anybody. So if they alert you to something concerning, sometimes there's a tendency, particularly in people in staff, whether they're nurses or residents or even attendings, when they're tired or the patient family keeps hitting the buzzer, that you get frustrated with them and there may be an inclination to dismiss them, or, why are you bothering me again? Joey's fine. I've looked at him 10 times in the last 5 minutes. And then it's the 11th time when, you get burned. So listen to the parents. Look at the kid, look for vital sign changes. If all of a sudden they start vomiting and, little Susie never vomits, I don't know why she's vomiting. Things like that. Subtle changes sometimes are harbingers of a oncoming disaster.
What causes a subdural hematoma, like versus an epidural hematoma?
So subdural hematomas are almost always, I would say, with very rare exception, venous. There's a vein that has been, one or more veins that have been torn. And it's usually from a rapid acceleration, deceleration injury. Or, in a fight, you see these people who are combat sports, boxers or MMA fighters, who get a really bad hit and they pass out, and then you hear that they die. They die from a subdural. So the brain shifts inside the head because there's a little extra room. We have spinal fluid. And when they shift, they tear the veins that bridge into the superior sagittal sinus. Typically, that's where the venous bleeding is. And the blood starts to gather over the whole surface of the brain. If you remember subdural, it's underneath the dura. There's nothing to keep the blood from collecting, and it covers the whole brain, and it gets bigger and bigger, and the overall volume of blood can be significant.
Could you say that one more time? I'm trying to write this out as you're saying it.
So where you put under the dura on epidural, it's under the dura for a subdural. Oh. So brain shifts, tearing the veins, correct? Blood starts to gather under the dura. There's nothing to contain it. There's not like a cranial suture where the dura might be stuck and stops the clot from growing. So the blood can go over the entire hemisphere. And there's a very large space where it could potentially gather, and it will. And even though on one cut on a CT scan, the subdural may not seem very thick, if you think about that thickness over the entire side of the head, well, that's a big volume, and that creates a huge mass effect. So an epidural hematoma, epidural is outside the dura, or some people say extradural epidural. So that is blood that is almost always arterial in nature, not venous. Classically, it's actually from the middle meningeal artery. So there's a little artery that comes from the external carotid. It goes through the bone, through the, it's called the foramen spinosum. It's one of the foramen, the meningeal artery goes, just say, through the skull and feeds the meninges, feeds the dura. And oftentimes fractures go right through there. And since the artery is going through the bone, the fracture tears the artery. And they start to pump blood into the epidural space. And that's why earlier on, I saw, Cindy, that you wrote on the previous slide, that epidurals can grow very fast. That's why they grow fast, because they're arterial in nature. Sometimes, though, they're confined in their size because the dura is stuck to the suture. So if you guys can see my head here, if there's a bleed here, there's a coronal suture here, and there's a lambdoid suture here, and there's a sagittal suture here. So usually the epidural is confined to where the sutures are. But if it can't grow, over a large area, it'll get thicker and thicker. And as it gets thicker and thicker, it'll push the brain more and more. That's how those things grow. So the answer to the question, what causes a subdural tearing veins? What causes an epidural typically tearing an artery?
I think that's a really good way to help everybody remember.
And it's typically, have we seen?
Yeah.
Have I seen epidurals that are from venous bleeding? Of course, yes, but it's usually arterial.
How often do you see a skull fracture being the cause of the epidural? Like, is there any other thing can you get an epidural without a fracture?
You can, particularly up here frontally, or back here if there's a fracture. Let me answer your first question. Very often.
Okay.
I can't give you a statistic, but very often. There's almost always an associated fracture. So it could be that the fracture bleeds, the bone has, venous blood in it, and the blood bleeds into the epidural space. As a matter of fact, sometimes we'll see a kid who has a fracture, an epidural. It's not very big. We re-image them, and 4 hours later, make sure it's not getting bigger, and it's gone. Well, where did it go in 4 hours? It probably leaked through the fracture underneath the scalp. Sometimes there's a fracture and there's bleeding underneath the scalp, but not in the epidural space. So those are venous epidural bleeds, typically from the bone.
Okay, that makes sense. How has head injuries and/or treatment changed throughout the years? Because you've been here for a while, so
during my time here, not very much. One thing that has changed is we don't cool patients anymore. We used to. There are some very large studies were done about hypothermia for treatment of intracranial hypertension in closed head injury, and it turns out that the relative risks of that outweigh the benefits. So that has become, I think it's been quite a while since we've cooled a patient. The use of hypertonic saline has become prevalent. When I was training, we didn't use hypertonic saline. Surgical management is about the same. There have been studies, and we've done a few here, where we put oxygen monitors directly in the brain to manage head injuries. We haven't done that very often because most of these monitors are really, really big. And they were called Lycox monitors. I don't know if you guys remember, but we had some complications from those with epidural hematomas being caused by the monitor and stuff like that. So, Mike Bell, who's the head of the ICU and is essentially a world expert at the management of closed head injury, could probably answer this question better. But I would say no hypothermia, but the onset of hypertonic saline have probably been the two most significant changes over the last 15 years.
You any reasons why hypertonic saline has become like such a thing? And is this like in place of mannitol? I mean, because there's always that argument of like mannitol or hypertonic saline.
I think that in our protocol here, hypertonic saline is used as a more common management tool, and mannitol is used a little bit for spikes that become a little bit out of control if hypertonic saline isn't working. The problem with hypertonic saline is, as you know, is it's hypertonic, and you can end up having very bad sodium shifts, which will come back to burn you, right? So I think that concern is why it may have not been as commonly used in the past, but our ability to follow that, to control that, is a bit better. I mean, overall ICU care, both nursing and medical care, physician care has invariably improved. I mean, you save patients all the time that would have died in the past. And that includes like, non-head injury patients with sodium issues, craniopharyngioma patients who are fan-hypo-pit have diabetes insipidus, or kids who show up with medical diabetic issues. We're just much better at managing both hypo and hypernatremia. Hypernatremia being the main issue with hypertonic saline.
There are some EMS agencies that are trialing hypertonic saline in the field. Some are using 3%, but some are using 23%. Is that something you would ever see that percentage in pediatrics? This is more for adults that these studies are being done in. But
yeah, that's a bit more for the medical people than for me. But 23% is, I suppose, if you're almost dead and your ICP is high, anything that might help, you know?
Right.
I remember many years ago, I wrote a chapter on closed head injury for my boss when I was a resident. And at that time, people were really, really starting to use hypertonic saline. 3% was becoming common. And 7% was considered crazy. So 23%, yeah, I don't know enough about it to comment, Cindy, but I suppose anything that can be managed, you know, you have to be able to manage the complication. So any complication that might come from that, if it can be managed, they'll probably try to institute it. But everything trickles down to children after adults, right?
Right.
For obvious reasons.
There's a lot of like one side versus the other in adults and EMS for this particular protocol. And one of the ways that they were saying is you just don't have to have as much volume when giving it. But one of the things that they have to have is an IO in place to give it. So if you're putting in an IO in like a 911 system in an adult, like they're going to be unconscious with a massive head injury. So it's, you know, but yeah, I found that interesting. And I was wondering if you had ever heard of it in kids, but I'm glad that it's going to be in a long, long time. It seems scary to me. How do providers decide when to prescribe Keppra for seizure prophylaxis?
My criteria is if there's an intraparenchymal injury, you know, so if there's blood or a contusion in the brain, and that would include a subdural, because the subdural is like on the surface of the brain, right? It's touching the brain. An epidural is not. Between the blood and the brain is the dura. So I typically do not ask for anticonvulsants for epidurals. Some of my partners do, I do not. But usually the criteria is a direct injury to the brain. Now, a little wisp of subarachnoid blood, probably not. A contusion, for sure. Intracerebral hemorrhage, for sure. Subdural, for sure. But you'll see sometimes, you know, I'm assuming that the question was asked because you've probably seen patients 5 different patients with similar injuries, and half of them were on Keppra and half of them weren't.
Yes.
So
yeah, I would agree with that.
So that's sort of dealer's choice, and usually that's driven by us, or at least we're asked, and oftentimes we're overridden by either you guys or by the neurologist. But my own criteria, I need to have a real concern that the kid's going to have a seizure, and you usually don't seize from an epidural. You will seize from a subdural. You will seize from a significant injury to the parenchyma of the brain, and a little bit of subarachnoid hemorrhage. No.
If a child has a brain injury and they have a seizure, no matter what type of injury it is, would you give Keppra?
So that's a great question, because we see contact seizures all the time, right? Kid whacks their head, has a seizure, and passes out. Or whacks their head, passes out, and has a seizure. A one-time contact seizure, no, I would not give them anticonvulsants. If they have a second seizure, yes, I would.
I think that's interesting too, because I've seen like all of these cases, and I always knew like we're trying to prevent seizures, but like which kids are like more at risk for that, and I feel like that's really helpful. Other than trauma, what are some other things that causes brain swelling?
You know, an ischemic stroke, right? There are a lot of So brain tumors can cause, peritumoral edema. Sometimes you'll see a small tumor with a huge amount of edema, i.e. swelling. There are, other medical issues like chemotherapy. Some chemotherapies can cause brain swelling. A meningitis or a cerebritis, some type of intracranial infection, whether it's viral or bacterial. Sometimes, particularly viruses, tend to affect the cerebellum, and you'll see a cerebellitis. You'll see this swelling of the cerebellum. They can even cause obstruction of the fourth ventricle and hydrocephalus. Those are the main things. I'm sure there's other things I can't think of right now. The neurologists take care of children who have swelling from other, non-mass, non-neurosurgical lesions.
So and if a kid has hydrocephalus, that's not swelling of the brain. That's just swelling of there's more fluid in the ventricles.
Correct.
I feel like I should add this to the list because that's going to cause increased ICP at the same time. What do you think?
So that's a different question. What other things can cause increased intracranial pressure? Yeah, tumors, strokes, hemorrhages, infections, abscesses. In rare cases, an actual vascular malformation can be big enough to cause mass effect. In a baby, a giant aneurysm. These are rare things, but they can all cause increased ICP.
I think it's important that we talk about both because they're both can be problems. And then our last question from the evaluations is, when symptoms are missed or overlooked, what symptoms are missed or overlooked when a patient has a closed head injury? So you coming to the bedside going, you missed the boat. The patient had these signs and you missed it.
From a head injury, usually it's meant, if you're going to miss something, it's going to be because they're comatose and you haven't been able to follow their exam and you didn't look at their pupil, right? So pupillary change in a comatose patient. You may see a pupillary change without anything else, right? The heart rate's not going to change, the blood pressure's not going to change, they're intubated, they're sedated, they're paralyzed, so you don't have much to go on. And for whatever reason, their ICP, if they have an ICP monitor, hasn't, there's been a variability all night. So sometimes they're 15, sometimes they're 21, they come back down. And then you look at them and their pupils dilated. So the two usually go together. It's unlikely you're going to have pupillary dilatation as a significant change without a concomitant increase in ICP, but it can happen. In a patient who's not comatose, usually either they're becoming, particularly in a little kid, they're becoming irritable when they weren't irritable before, because that's how they usually communicate their discomfort, irritability. A change in their alertness, even if they're awake, if all of a sudden they don't know their name or they can't spell their name or they don't recognize their parents, those are early signs of something bad happening. Those are the things that I think are missed the most. Like, how could you not have picked this up? Joey was, so happy yesterday, and today he's puking everything he has and just keeps pushing you away. Particularly, like teenage kids who, the classic example is the moderate head injury, the kid who's whacked his head and looks pretty good and then starts cursing and using bad words and getting up and peeing on the floor rather than the bathroom. Those are signs that something, even though they're moving around and they can even get out of bed, those are signs that something bad is happening. Particularly like the progression of some frontal lobe contusion, where it may not affect their strength or their breathing or their swallowing or their heart rate or their blood pressure, but it will affect their personality.
Okay. So for those of us who have joined us online, This is your time to feel free to ask any additional questions that you have. We have Dr. Myseros for about 5 more minutes. I'm putting the evaluation link in the chat so you don't have to try to write it down. And I'd be free to just answer. We can answer any questions. You can either unmute yourselves or put it in the chat. Dr. Myseros, thank you so much for coming today. I think this was really helpful. I've had a couple people text me on the side saying this is really great, and thank you for doing it.
Thank you for having me. This is the first time we've ever done this, Cindy, you or anybody else. So I think it's good.
Okay, cool. Yeah, I think I feel like especially trauma core is, geared towards our newer nurses, and sometimes it can be a little bit overwhelming to get all of this information for the first time. And I feel like I was hoping that this would be like a good way to reinforce some of the most important things.
I think it is, particularly if I'm hoping the people that ask the questions the first time zoomed in to do this, but usually it doesn't take a lot for something to become habitual, right? So, or to learn something. If you hear something once and then over a short period of time you hear it again, it's a little more likely that it'll stick. And not everything, some of the stuff that I've told you guys is my opinion or my practice or my, my intuitive thought about something, but you could get other opinions from other people. Most of what I told you is fairly standard though.
Yeah. All right. Well, I think we've given an adequate time for questions. I'm going to go ahead and stop recording.